Recording in
which is rich of various cultures and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang, make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, Teaching Hospital, and Dental Hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Padjadjaran, straightening and developing together with society. From West Java, for Indonesia, to the world, through SDGs.
Greetings from Transcendence 2021 Massive Open course in Cleft Lip and Palate held by the Faculty of Dentistry Universitas Padjadjaran in collaboration with Smeltrain and Indonesian Cleft Center has been going on for a few weeks. We are currently in the 8th week of Cleft Lip and Palate course. My name is Josephinda. I'm a dental student from the Faculty of Dentistry Universitas Padjadjaran, Indonesia, and I'm so honored to be the master of ceremony of today's live discussion. I see that we came from different countries, so I think it is appropriate to say good morning, good afternoon, and good evening to everyone here. Also, greetings to our expert today, Dr. Ikenna Gerald Isiekwe from the Faculty of Dental Science, College of Medicine, University of Lagos, Lagos University Teaching Hospital, ID Araba, Lagos, Nigeria. Thank you for being here, Doctor. We are so honored by your presence here. How are you, Doctor?
Very fine, thank you. Thank you for having me. Thank you for having me.
Thank you so much, Doctor. Thank you for giving your time here, and I hope you are doing well.
Very well.
And we also have our moderator today, Dr. Erli Sarilita, Magister of Science, Ph.D. She is one of my lecturers in Faculty of Dentistry, Universitas Padjadjaran. How do you feel, Doctor?
Great, thank you, Vinda.
Okay, thank you very much, Doctor, for giving your time here as today's moderator. Greetings to all participants here, especially for Indonesian students who have just joined this course from the KMME program. Thank you for participating in this course and thank you for attending this live discussion session. First of all, I would like to explain about this live discussion. So this live discussion will be separated into two sessions. In the first session, the expert will be answering the questions that have been filled out by the participant on the MOOC platform. The question will be presented on the screen. And the participants have already watched the lecture video about the related topics, which is outcome measures of assessment for oral health and dentofacial aesthetic in patients with orofacial clefts. So they have seen your lecture, Doctor, even though I think not everyone can make it into this live discussion, but don't worry, I'm sure that all other 800 more participants that have registered for our course have watched your lecture video as well, and they will watch the recorded live discussion session. Next, in the second session, the participants will have the opportunity to ask the questions directly to the speaker through the Zoom chat, and they will write down the questions, their name, and where they are coming from. or the participant can also unmute their microphone and ask directly to the expert in the second session. Now, I would like to give the spotlight to our moderator, Dr. Erli, and Dr. Isiekwe as our speaker. Dr. Erli, you may start the first session and lead today's live discussion. Thank you so much. Now we are moving on to the first session.
Thank you, Finda. Dr. Isiekwe, how are you?
I'm fine. Thank you, Dr.
Thank you very much for giving your time to share with here today in Indonesia, and also we all have participants from different countries in different continents. Okay, doctor. So as our Master of Ceremony mentioned before, that some students already posted questions in the massive open online course, and most of them already watched your lecture. It's a really interesting lecture, and it's important, really important in evaluating the treatment of the cleft lip and palate patient. So perhaps committee, can you help me to display the questions from the students? Okay, the first question from Shiva, Universitas Pajajaran, Indonesia. From the lecture, it is said that outcome measurement is important for deciding whether a treatment works or not. Should a patient know about their outcome measure, and what are the advantages of a patient knowing their outcome measure? Please, doctor.
Okay, so it's a very good question. And you know, if you remember in my lecture, I mentioned that outcome measures are twofold. You can have clinician-reported outcome measures and patient-reported outcome measures. Now, for the clinician-reported outcome measures, the primary reason why we want to do that is to audit the quality of care that we provide, with the aim to seeing whether the techniques we are using, whether it's surgery or orthodontics. For my lecture, it was specifically for dentofacial outcomes. So we're looking at the dental outcomes, the effects of surgery on maxillary growth, the oral health of the patient, the dentofacial aesthetics. The primary person who wants to know about the outcome is the clinician, but the patient also deserves to know what the outcomes are. The interesting thing is that even without asking our patients, they already rate our outcomes. That's why we have patient-reported outcomes. If you have a child with cleft lip, the mother looks at the repair and she can say, oh, my child is looking beautiful. My child is looking better. So you can have clinician-reported and patient-reported. The patient-reported outcomes are important to the patient and to the clinician. So both of them should know to answer. I'm giving that background before I directly answer your question. It's important for patients to know the outcomes of their treatment. But the truth is that in a condition like cleft care, the patient already knows the outcome. The child has a cleft lip, you do the surgery, they see the lip is repaired. Now they can assess that outcome. The child has a speech defect as a result of a cleft and undergoes speech therapy. The outcome of the speech therapy is the child can speak better. So what I want to say is that patients always see the outcomes of what we do, even without us asking them. The problem is, are we taking into consideration as clinicians how they see the outcome? Outcome measures are good. What we've always done in the past as clinicians is that we focused on clinician-measured outcomes. We focused on what the doctor, we're going to look at the Asher-Margate scale, the DMFT scale for caries. That's the clinician-based outcome measure. But what we are moving towards now we're going towards patient-centered care, where we are focusing on outcome measures as reported by the patient. And then we, the clinicians, look at what the patients see, how they perceive the outcome, and we model our treatments to focus on patient-reported outcomes. So that is what that is what we are going to, not just for cleft care, but I mean, medicine and dentistry as a whole is going towards patient-centered care. So the advantages of a patient knowing their outcome is numerous, but it is the patient's perception of their outcome that is going to be driving a lot of the decisions that will be taken in, not just in cleft care, but in medicine and dentistry as a whole. So I hope that kind of answers your question that should the patient know about their outcome measures? Yes, they should. Yes, they should. And I want to add that they already know. What I want to twist this question to say, should the clinician know about the patient's perception of their outcome measure? I want to add that to this question and say yes. And that's why we have patient-reported outcome measures, which I presented in the last part of my lecture, where I talked about cleft Q and questionnaires to assess patient satisfaction with cleft care treatment. So I hope that answers the question. Thank you.
Thank you, Dr. Isiekwe. We still have more questions coming. Next, committee. From Argi Marsiadina, Universitas Padjadjaran Indonesia. From the indexes that you mentioned in the lecture, what is the most common index that is commonly used in today's practice?
Very, very good question. If you remember in my lecture, I talked about different assessments, different indices for different assessments. So if I wanted to just a few, just to highlight a few, if you want to assess maxillary growth, Gosden index is the most commonly used index to assess maxillary growth all over the world. So the Gosden rating is the most universal. The closest to it is the 5-year index, but the Gosden index is the most widely used for maxillary growth. I mean, for caries, we all know that as dental students, practitioners, the DMFT index is widely used for that. For dentofacial aesthetics, the Asher-Magdate scale is the most widely accepted. The Asher-Magdate scale that describes the syllabial aesthetics. I spoke about that in my lecture as well. For some scales, for alveolar bone grafts, there's still a lot of controversy. There's no universally accepted scale, but a lot of people tend to use the Kinderland scale. But in that regard, a lot of studies have not been done, particularly with respect to alveolar bone grafts. In terms of patient-reported outcome measures, which is a follow-back to the first question, a number of scales have been used. There is no standardized scale yet. The most recent standardized scale that has been developed is the cleft Q. Cleft Q was developed just a few years ago. It's a cleft-specific scale that assesses outcome based on aesthetics and function. So the cleft Q is a new scale, relatively new scale, but it's not been widely used yet. So that's just a brief rundown on the different scales for the different measures with respect to dentofacial outcomes. I hope that answers your question in terms of.
Okay. Yes, that's right, Doctor, because it depends on what domains are we talking about, and then after that, what subdomains are we talking about, and then we can decide the instruments. Yeah, that's right.
Very true.
Next question. From Adira Kansa, Universitas Padjadjaran Indonesia. At what age is the assessment of dentofacial aesthetic is done?
So the word dentofacial aesthetics is a compound one. And just like the last question, you can actually talk about dental outcomes, and you can talk about facial aesthetic outcomes. So if you want to talk about the dental outcomes, which looks at maxillary growth, I want to talk about the Gosden rating. You want to talk about the ratings that are used to assess maxillary growth. The Gosden rating is very commonly used, and you have the 5-year index. At 5 years old, you can use the 5-year index. Some literature say you can also use the Gosden rating at 5, but the Gosden rating is used for slightly older children between the ages of 8 to 9, 10 to 12, and these references are making are specifically to maxillary growth. Then when you go to dentofacial aesthetics, where you're looking at nasal, the Asher-Magdate scale, that you can actually do that in the newborn. You can do that immediately after the cleft lip repair has been done to assess the outcome of the cleft lip repair, and you want to look at nasal symmetry and all that. So when you say dentofacial aesthetics, like I've just tried to separate it for you from. You can actually start from, for dental, you can start normally 5 is good. So from 5, so you have some studies, outcome studies have done 5 years, 8 to 9 years, 10 to 12 years, you can use the 5-year index of Boston rating. And for facial aesthetics, you can use the National Marketing Scale immediately after the lip repair has been done, or other scales as well. So I hope that answers your question. So the ages vary based on the type of assessment that you are doing, whether it's dental outcome or facial aesthetics.
So I have,
sorry, just to add that you can also assess, and I mentioned in my lecture, you can also do cephalometric assessments as well to assess the skeletal relationships and dental relationships as well. And those radiographs are normally taken about 8 to 9 years as well. That's for radiographic assessments. So the type of assessment is carried out. The timing depends on the specific type of assessment that is being carried out and with the outcome that is being measured.
Okay, doctor. So I have a follow-up question from this. So because each subdomain has each instrument, does each assessment has its own standard timing? For example, to assess nasolabial aesthetic, it has to be done, let's say, 3 months after the lip surgery. Is there any specific or standard timing?
Yes, there is standard timing. It's standardized in order to be able to, for you to be able to compare the outcomes. And then you also want to standardize with respect to the age of the child, particularly for not just for the cerebral aesthetics, like I said, but for even the dental outcomes as well. Because if you don't standardize the age, the outcomes may be different for different individuals. So what is done? So the problem we have in outcome studies globally is that for a very long time, different centers have carried out their outcome measures at different times, and so there's a lot of, although there's an attempt to try to standardize. There was an international committee on outcome measures that was established sometime 2000 in the mid 2000s, between 2005 2010, to try to develop standardized outcome measures that will be used worldwide. So I'm sure we probably know that there are things like the Scandi clefts. The Scandinavian countries have come together to develop outcome measures. We have the Ameri clefts, where in North America they've done studies. You have Euro clefts. Euro cleft is one of the earliest, where in Europe they came together. So most of these studies have developed their own timings, and sometimes they have to state the times at which they do the assessment for comparison, for reasons of comparison. But generally, for all the assessments, whether it's speech, speech is a bit later, but in order to carry out the assessments in a synchronous manner, the outcome measures that the international committee set 4 main ages: 5 years, 8 to 9 years, 10 to 12 years, and then in late adults, they put that. So they said, in fact, at birth, where you do the basic height and weight and basic of the child. At 5 years, like I said, 5 years, you've done the cleft lip and palate repair. Child has done some speech therapy. I said before, 8 to 9 years, 10 to 12 years, and adults now. At this age, they do all the assessments that I've mentioned that can be done. You actually can do speech. You can look at dentofacial aesthetics. You can look at dental aesthetics, facial aesthetics. So, for instance, the cerebral aesthetics you can do at the age of 5 years, at the same time as you are doing the dental assessment for Boston rating or the 5-year index. What they try to do, because this is a very good question, is that they try to put these ages as standard ages where major assessments should be done, so that if I want to compare cases in Nigeria with cases in Indonesia, I know that the age at which the samples, the data was collected, whether it's for...
I think we lost our speaker. Vinda?
Yes, doctor. I think the connection is lost in the Dr. Isiekwe connection.
Okay, we'll just wait.
Since I see that there is a lot of Indonesian students here, please don't forget to follow our Instagram in instagram.com/transcendence.fkg4 because there is a lot of information there about this course. So please follow them so you don't miss out any information.
Silahkan yang mau bertanya disiapkan di chat Zoom atau mungkin nanti langsung juga on cam untuk bertanya ya. Pertanyaannya ada berapa, Vinda?
Untuk pertanyaannya masih ada what age itu masih ada satu pertanyaan lagi dokter di PPT-nya.
Okay. Saya ada satu lagi pertanyaan.
I apologize.
Yes, hello, doctor.
No worries. Yeah, no worries, doctor.
I apologize. Sorry for, I think I lost my connection there, so I'm sorry about that.
That's fine, doctor.
Sorry about that. So sorry about that. Sorry about that.
No worries. No worries at all.
Fine, doctor.
Yeah.
So I think that addresses the question that, just to summarize that, assessments are done at standardized times to allow for comparison of these outcomes even across centers within the country, across countries, and even, across regions, So that's basically it. And I referred to those times earlier. Thank you.
Okay, we will move on to the next question from Kanza. According to the lecture, it was said that for assessment of nasolabial aesthetic have 5 principal scoring system, and the Asher-McDade system is commonly used. What are the factors, especially from patient's condition, that could affect the scoring system?
Basically, that's a very good question. Basically, the outcome, because the beauty of the Asher-McDade themselves and the outcome of the repair, what the Asher-McDade is actually doing is to score how a group of professionals, can be an orthodontist, the surgeon, the speech therapist, how they perceive the outcome of both the nasal symmetry. You have 2 photographs. If you remember the lecture that I gave, you had a photograph of the patient which had been screened off to allow you only see the lip and portion of the nose, and then a picture of the patient in profile. So basically, what could affect the scoring is the outcome itself. Where you have a very, very good outcome, in terms of the lip repair, because what the Asher-McDade scale is assessing is the outcome of the lip repair and the impact that the outcome of the lip repair has, 1, on the lip form itself, and then 2, on the nasal symmetry. A very good lip repair will leave the nasal form in a very good position, and you would have you have good symmetry of the nose. You would also have, the cupid's bow and the lip line and lip form looking very good. So the things that would affect the scoring would be the nasolabial aesthetics itself and the lip form. So where you have very poor outcome, you will have a very poor grade on the Asher-McDade scale.
Okay, doctor, thank you very much. I think that is the last question from the MOC. Is that correct, Vinda?
Yes, that is correct, doctor. We will moving on to the second session, doctor.
Okay, while we're waiting for the audience here to post their questions, I have one question for you, Dr. Isiekwe. So, in your country, so there must be many cleft centers. Are they doing the same treatment outcome measures for each subdomain, or there are variety in different centers?
Yeah, thank you, Dr. Erli. So it's a very good question to start with, because we haven't, outcome measures is something we are not yet doing properly in Nigeria. That's being honest. Thanks to Smile Train, that sponsors the surgeries that have been done and is sponsoring comprehensive cleft care. So we were able to do orthodontics. That's why I'm able to come in, and then speech. We do speech, nutrition support, the anesthetic care, other aspects of team care. But right now, one good thing that Smile Train makes its partners to do, and I'm sure you can tell from Indonesia as well, is that we have to report our cases, upload them to the STX so that they can track what each partner is doing, each center is doing. And so that's a small type of audit, but that's being coordinated by Smile Train to make sure that donor funds are used as they should be used for, and to be sure that to monitor our outcomes. Sometimes they say the procedure is good. If you look at the STX, they say the lip repair is good, or a repair might not be accepted. So that's Smile Train. But in terms of having a standardized nationwide outcome protocol, we don't have that. And that's one of the things that I'm strongly advocating for. And when you go to conferences, you hear about so why can't we have Nigeria clefts or Indo clefts? I mean, and that's just bring together all our cleft cases and say, how well are we treating? If you compare my center with your center, which is in Nigeria, is there something we could do better? So in Europe, what they have done is that they have standardized the outcome measure is part of the treatment, is part of the protocol. So in the UK, you have a treatment clinic where the patient just comes in to take all these measurements at these stages, just to get them. So they have the record, so they can put it together. So pushing for personally, and that's a research project that I want on. We are doing it subconsciously under Smile Train because we have data now that is being collected in an organized manner, photographs, but they are not standardized in the sense that we don't have, like, I can't tell in my center now, we haven't done an outcome study to say, okay, how well have our patients, how well has been the surgical outcome of patients treated at Luth? So that means I have to get all the models for all the 8-9-year-olds and then do a proper assessment and validate with other orthodontists. I haven't done that. We haven't done that. It's not something we are doing right now with Nigeria. So that's for me, that's the next step, to try to do something within the country. I mean, start from my center. Our average outcomes for maxillary growth, our average outcomes for nasolabial aesthetics, so so I have to be honest, we haven't started yet. But when I presented this lecture a few months ago, between that time and now, that process has started. So we are going for ethical approval. We're going to have, we're having some studies in my center, and we're going for a nationwide, at least with some key centers, to start to do something conscious so that we can report, study our outcomes and know where we can get it better, one. Secondly, we can share our outcomes with other parts of the world and say, this is what we have in Nigeria, in West Africa, in terms of the outcomes of our patients. And maybe we are doing something right that the world can learn from, or maybe there are some things that we could do better when we go back and look at those values and those reports. So the importance is, it's something that I would say is really very, very important. That's the stage where we are right now. I hope that answers your question. I don't know what you have over there, just to trade. I don't know if you're doing something like that already in Indonesia.
Actually, Dr. Isiekwe, we haven't done that either. So I'm really thankful that that Smile has played a huge role in improving the cleft care in Indonesia, and hopefully maybe this year or in the next year we can start that protocol that treatment outcomes is part of the protocol. Is not a additional stuff to do, but it's part of the protocol that we have to do treatment outcomes measure so that we can evaluate each treatment that we provide to our cleft patients, because as we all know that cleft patients requires different types of treatments, from feeding, dental and oral health, and then surgery, of course, and then psychology, all aspects of treatments. And we need to evaluate our centers in order to improve our service to the cleft patients. And I'm really thankful that Smile is part of that, because unfortunately until right now in Indonesia there is a lack of government support in terms of that. So we have to rely on Smile Train to help us. That's right.
Yeah.
There's a question from the audience here. From
Actually, the participant, one of our participants have raised their hand, Doctor.
Oh, yes. Okay. I will give the opportunity to Faras. Okay, Faras, you can ask the question.
Okay, thank you for the opportunity. Hello, doctor. My name is Faras Reza from Universitas Pajajaran, Indonesia. I want to ask, are there any cases where the patients or their parents are satisfied with the outcome of the surgery because it is functionally good, but according to the clinician, the aesthetical aspect is poor? If there are, how do you manage that? Thank you, doctor.
Thank you, Faras. That's an interesting question. What you're asking is there a situation in which the patient perceived outcome is different from the clinician reported outcome? And you know, it happens all the time. It happens all the time. Sometimes it's the other way around. Sometimes it's the doctor is happy, the patient is not happy. But in patients with clefts, what happens very often, it happens in Nigeria, I'm sure maybe that's what happens. The mothers are excited. You know, the child comes with a cleft lip and you do a repair. Now, she's happy that that gap is closed. Do you understand? So the clinician doesn't feel it's a fantastic repair. Maybe you do the Asha McDade scale. The mother doesn't know what Asha McDade is. You understand? You are the clinician. You know all the Asha McDade and you know all the scales. But the mother is happy. Now, for the clinician, what we normally do is, normally the clinician says, normally the clinician looks at it and says, oh, madam, this is, we like this, but we feel that it can be better. And normally they do it. So they explain to the mother that we still want, even though you're happy with what you have, we still want to make it better. And such patients often get like a revision of the scar and all that. So it's not a bad thing. One thing that I've learned as an orthodontist is that you must always provide, sometimes, and it's not intentional, we tend to get carried away with our measures, you know. We call the patient, like I was telling my students, that sometimes we forget the patient has to say we tend to look at the case without the patient. The fact that the patient is happy is a good thing. That's a positive psychological outcome. As a clinician, you want to give the patient the best. So you're going to try to tell the patient that even though you're happy with this, we feel it can be better, and we hope to do a revision of the scar at a later date. And the mother is happy that, oh, even with what I'm happy with, the clinician still wants to make my child look better. So that's a win-win. The tougher scenario is when it's the other way around. When the doctor is happy and the patient is not happy. But with cleft patients, it's not as common. It's commoner in other parts of It's common that when I'm an orthodontist, I know when there are sometimes when I feel like excited about what I've done for a patient, the patient is like, this problem is still not okay. So, but with patients with clefts, it's not normally like that. But even then, I just want to emphasize that what I've learned is that you can never get it wrong from listening to the patients, because they know sometimes we tend to focus as a clinician only on our own outcomes and forget about the patient. So that's why the patient-reported outcomes are really important. To ask the patient, how do you feel, madam? How do you see his face now? How do you see her face now? Are you happy with what has been done? Does the child look better now? Most of the times, 95% of the time, they'll tell you yes. Then you now, as a clinician, you now say, okay, we can still make it better, and you tell the patient how and what you want to do. Thank you.
Thank you so much for the explanation, doctor. It was very clear.
Thank you, Faraz.
Thank you, Faraz. Okay, we have questions, Dr. Isiekwe, from the chat box. From Echa, good afternoon, sir. I would like to ask, why is the Goslon yardstick index most suited for early permanent dentition? And what will happen if it's used before the child reaches 10 years old? Thank you. You're still mute?
Yes, that's a very intelligent question. And, and that's from Echa. So Echa, you know what happens there? In the literature, in research, the first index, the Gosden index was like the major index that was accepted worldwide. There are other indices with that Gordonham and all that. I won't bother you with all that. I mentioned them briefly in my lecture. Now, Gosden assumed a worldwide acceptance because, although you need to be calibrated and trained to assess with Gosden, you need to have the standard Gosden models that were used in order to know what Gosden 1 to Gosden 5 is. But it's the most widely accepted. Now, when the argument came up that it would be better to assess children at 5 years of age, because when the child is 5, the child has just done only the lip repair and the palate repair, and the child has not undergone any form of orthodontic treatment. So at the age of 5 years old, that's the best time to assess. That in the literature, the argument was that would be the best time to assess for maxillary growth outcomes. And then they developed the 5-year index in Bristol, University of Bristol. So you have the 5-year index. Now, already at this time, you already had the Gosden rating, which was designed for use of between 8 to 9 or slightly older age children. And so the argument came up, which is better to use? Do we use only the 5-year index, which is for 5-year-olds? And it's used for 5-year-olds because at that time, it's believed that the jaw has not experienced orthodontic treatment. At 8 to 9, you know that some patients may have undergone maxillary expansion, and that may distort that relationship they are trying to assess when we are doing the Gosden rating. But after that, so after the 5-year index was developed, there was a lot of argument back and forth. So there's a study in the literature, I think it was published in Cleft Palate Orofacial Journal, where they compared Gosden at 5 years old. They used the Gosden rating at 5-year-old, and they used the 5-year-old index for 5-year-old children as well. And they found out that the difference was not too much, that you could actually use the Gosden rating for 5-year-olds, although it tended to overestimate 1 or 2 classes, but it was still appropriate. So you can even use the Gosden rating for children that are slightly younger than 8 to 9 years old. However, what is commonly done in the literature is that if a child is about 5 years old, they tend to use the 5-year index because it was developed for children that are 5 years old. While when the child is older, 8 to 9 and above, they can use the Gosden rating, even though the Gosden rating is acceptable for slightly younger ages than 8 to 9 years old from the study. But because the 5-year-old index was developed for 5-year-olds, so when you go into the literature for the 5-year index, then when they get to 8 to 9 year old, they use the Gosden index. 10 to 12 year old, use the Gosden index. And so I hope that answers your question in terms of the disparity between the 5-year index and the Gosden index. But don't forget, 5-year index is just for 5-year-olds. Meanwhile, the Gosden has a wider range of use. So that answers your question.
Thank you, Dr. Isiekwe. We still have one more question from the chat box from Nur Hadi Kusuma. I would like to ask you a question. Some of cleft patients have systemic syndrome like heart defect, etc., that needs a multidisciplinary approach. How do you manage such patients in your country?
And that's very true, because we know that we have some syndromic cleft cases that are presenting with other, comorbidities apart from the cleft. So what we normally do, our protocol is that when a mother or a child is born with cleft lip and palate, before we do anything at all, before any surgery, before even the cleft lip repair, we send the child for an assessment by the pediatrician. And then the pediatricians do an echo, and they do a thorough clinical assessment, radiographic assessment, to rule out any, congenital heart defects that may be present. Where those are present, then we want to ensure that the surgery, whatever planned surgery that surgery is planned for the child, will not affect or hamper the medical condition of the child. So we manage such patients with the pediatrician. The presence of a heart defect, if the heart defect is not life-threatening, it may make it difficult, may mean that that child going on for anesthesia for surgery may have issues with anesthesia for surgery for cleft lip repair. So until we are given an okay by the pediatricians that the child is, able to withstand the stress of surgery, we do not go ahead with surgery. And that's the whole idea of the team effect in cleft care. One thing that my center has is that it's a team. So the pediatricians assess the child. We don't carry out surgery on any patient. No surgery unless the pediatricians give you the green light to do so. And they will only give you the green lights when they are sure that that child, if they feel that child requires further management, then we would, of course, the cleft becomes secondary, because you need the child to be alive first before you carry out any other repair for aesthetics or function, which is basically what we are doing when we are repairing the lip and the palate, as the case may be. So that's basically what we do in my own country.
Yes, thank you, Dr. Isiekwe. That's the same thing happened in our center. So we work as a team. We always backed up by pediatrician. Before even the lip repair must be referred to pediatrician, make sure that the pediatrician's happy that these babies will go through the surgery. Then yes, and then also other type of treatments, including, for example, dental treatments. Dental treatments is complicated for syndromic patients. Therefore, also needs to be referred to the pediatrician, and if he or she says okay, then we will go through the dental treatments. I think that's the same in Indonesia. Thank you, Dr. Isiekwe. Maybe we still have questions from the audience.
I think that was the last question, Doctor.
Okay, that's the last question. If I may conclude, Dr. Isiekwe, please feel free to interrupt me if I said something wrong. That cleft patients needs multidisciplinary treatments, from surgery, feeding, speech, until psychological treatments. Everything, lots of different types of treatments that needs to be given by the cleft center to the patient. And we should start thinking not only how we give the treatments to them, but also how we evaluate the treatments that being given, so that the patient will receive the best treatment they can get. And in order to do that, of course, it will require multidisciplinary efforts, not only from dentists, not only from nurses, not only from the speech pathologists, speech therapists, also from social worker who approach the patient to, they can be, adhere to the treatment regimen that we provide. So it's it's a team approach with multidisciplinary background, because we have here Dr. Isiekwe, participants of the MOOC, not only dental students, not only medical students, but also we have nurses here. We also have psychologists here joining the online course. We also have social workers here.
Yes.
So it's a full team effort from different background. Yes. Perhaps Dr. Isiekwe, thank you very much for sharing your time here today. We really appreciate it, and hopefully we can follow your step in applying the treatment outcomes standardization in your cleft center. Hopefully we can follow your step maybe this year or next year very soon. From Faculty of Dentistry, Universitas Padjadjaran, Doctor, we are extending our gratitude for your time, Doctor. Thank you very much for sharing your valuable knowledge, and I'm sure the students here really appreciate your time here today. So, Finda, I will return the session to you.
Okay, thank you so much, Dr. Erli, for your time, and thank you so much, Dr. Ikenna Gerald Isiekwe, for your time. But before we end this discussion, I would like to take a picture of us. So I will take a screenshot of us, and the committee member can help me to take a screenshot of the participants today. To everybody who haven't opened their camera yet, please open your camera because we are about to take a picture. Okay, there is 3 slides of participants here. Please open your camera because these pictures will be also posted on Transcendence Instagram. So make sure to follow it so you can see the documentation of today's live discussion. Okay, so I think we can take the picture right now. So the committee member, please help me to take a picture. So I will count 1, 2, 3. Okay, next slide. 1, 2, 3. And last slide. 1, 2, 3. Okay, thank you so much. Now, it was a great opportunity for all of us hearing the valuable knowledge from Dr. Ikenna Gerald Isiekwe on this special occasion. In these hard times of pandemic, we can still find the bright side and learn another new thing in cleft lip and palate. Keep being motivated, pace yourself to learn, and continue completing these courses because you will be amazed by the knowledge you will have. My name is Josephina. On behalf of the Faculty of Dentistry, Universitas Padjadjaran, and the entire committee, would like to thank Dr. Ikenna Gerald Isiekwe as the speaker today, and Dr. Erli Sarilita as the moderator, and to all participants who have joined this live discussion, thank you so much, and see you on the next live discussion.
Thank you, Doctor. Bye.
Bye.